Awesome. It's good to be back live safely. Thank you, Dr. Bond, for the awesome introduction. Thank you to the faculty for being present today. I have so privileged to have Dr. Bond as my co-chair for the ACC Women in Cardiology chapter for Arizona, and we're very excited to present this case to you today. All right, so Alexis is a 38-year-old obese Black female. She presented to the urgent care with 6 hours of acute onset of exertional substernal chest pressure. She described it as non-radiating with no associated nausea, diaphoresis, but it was notable for shortness of breath, which did improve with rest. In terms of her past medical history, she's known to have polycystic ovarian syndrome. She was diagnosed 5 years ago with hypertension and prediabetes. This was shortly after the birth of her second child, which was in fact complicated by gestational diabetes. She was started on medications, and through aggressive lifestyle changes, including a 70-pound weight loss, she was able to wean herself off of medications. As such, she stopped her antihypertensive about 2 months prior to this event. Unfortunately, she has lost her job recently, and due to financial stressors, become more sedentary. She's regained her weight and started smoking roughly about 3 to 5 cigarettes per day. There's no history of any illicit drug use or alcohol use. And to help, she began taking an over-the-counter form of phentermine as a weight loss agent just the past week. Beyond this, she does not really state any medications or supplements. In terms of family history, her father had an MI before the age of 55. So this slide really talks about the risk factors that are present for cardiovascular disease in women that are well established. And as you know, this is an evolving topic as we find that more and more autoimmune diseases, particularly that women have, are becoming better known risk factors. So to the left there, you have your sex-specific risk factors: premature menopause, gestational diabetes, hypertensive disorders of pregnancy. I just saw somebody 2 days ago that basically had a hypertensive crisis on the delivery of her second child, and then kind of got lost to follow up a little bit and presented with really severe hypertension. Preterm delivery, polycystic ovarian syndrome, huge one. And then any systemic inflammatory and autoimmune disorder, thyroid, lupus, etc. Some of the under-recognized risk factors, I'm going to have Dr. Michos take over and speak to.
Right. So this case, what risk factors did this patient not have? But first I want to emphasize that she's 38. So unfortunately, like, our pooled cohort equations are calculated for 10-year risk starting, the equations are for ages 40 to 79. So these are, younger individuals are not even included in those 10-year risk scores, although you could do a lifetime risk score, which would be high. But she had a number of risk factors. She had polycystic ovary syndrome, which is associated with a twofold increased risk of future cardiovascular disease, although there's some question about whether this is causal or mediated through all the traditional risk factors that are associated with the hyperandrogen form of PCOS. She had a gestational diabetes, a history of an adverse pregnancy outcome. We know that history of GDM is associated with an 8-fold increased risk of developing type 2 diabetes, and she did develop prediabetes, but it's also associated with increased risk of incident hypertension and incident cardiovascular disease. She had financial stressors, and so it's important to really consider the social determinants of health. There's a tremendous mind, heart, body connection, and that mental health affects cardiovascular health. She had a smoking history. She had a family history of premature atherosclerotic cardiovascular disease. Her father had an MI before the age of 55. She was using phentermine for weight loss, which has, this is an amphetamine derivative for weight loss, and this has cardiovascular effects. So she had numerous risk factors, and we're going to get to this case where she had symptoms, but I see this as a missed opportunity for prevention. We don't know yet what her lipids are, what her LDL is, or whether she has other things, but whether she would be missed opportunity for early implementation of prevention. And we could talk about what screening opportunities we could have done earlier to help mitigate some of this risk.
Missed opportunity indeed. Would you have suggested that Alexis should have established with a cardiologist once some of the gestational issues had come up?
So it's really important for the handoff. So we've talked about this handoff, the fourth trimester, these transitional clinics for preeclampsia, but for all of the APOs, so as women with a history of gestational diabetes, 70 to 80% of them will have type 2 diabetes within 5 years. So it's really important that they had postpartum glucose measurement and that they get transitioned. Many of them develop hypertension, so they need someone following up. When to refer to a cardiologist. So when risk is uncertain, in my practice, I'll get a coronary calcium score for individuals with an adverse pregnancy outcome if it's not clear whether they benefit for statin or not. We don't know what her LDL is. She may already have an LDL high enough to warrant initiation of statin for primary prevention, but when risk is uncertain, I'll get a calcium score. Usually I don't start that till age 40 or above because it takes a while for plaque to calcify, but I will consider it sometimes selectively in younger individuals who have a strong family history or other risk factors, because although coronary calcium is less prevalent in younger individuals, when it is present, it is associated with increased risk, as we saw in the Cardio study. Another option is screening for other measures of atherosclerosis, like a carotid plaque. I don't use IMT, but carotid plaque itself is a measure of atherosclerosis that might be helpful in younger individuals.
Thank you, Dr. Michos. Dr. Rubenstein, could you please comment on what are the current recommendations for those with gestational diabetes in terms of follow-up postpartum?
Oh, thank you. Yeah, sorry. So on the postpartum component of it, I think that warm handoff and the tangible handoffs are an important part. That prenatal care, including the fourth trimester, is being redefined at this point by ACOG, but standard of care would be to give her the glucola, the 75-gram glucola. Whether they follow back up or have that care model has been another related issue to social determinants of health. Now family, second, third, fourth child, do they always show up for that? No, and I think there's a missed opportunity in that care and continuum, unfortunately.
Right.
Expansion of Medicare, obviously now as we move forward also beyond that even 60-day period, to 1 full year might be of proven benefit.
Yeah, that's an excellent point. Dr. Mamas, you are still with us. Wonderful. What is Alexis's pretest probability of heart disease at this time, sir?
I think it's really quite significant. I mean, the lady has presented with a 6-hour history of classical anginal sounding chest pain. She has a full constellation of cardiovascular risk factors that we've highlighted, including obesity, smoking, strong family history, hypertension, polycystic ovary syndrome. So I think in this sort of situation, we have to assume that she has significant coronary artery disease until proven otherwise, and we need to institute appropriate investigations towards this end.
Yep, absolutely. Thank you. So at this time, an EKG was done, which demonstrated normal sinus rhythm and no real ischemic findings. The patient was noted to have an excessively high blood pressure at 219 over 117 with an overall benign physical exam. She was given sublingual nitroglycerin because of the ongoing chest pain. In light of the concern for this hypertensive crisis with active symptoms, just as a reminder, she was having shortness of breath, the patient was transferred to the closest emergency department where she received a slew of labs, including a complete metabolic panel, a CBC, troponins, D-dimer, the D-dimer and the thyroid function panel were normal. She did get a high sensitivity troponin assay at time 0, and then 2 hours later, the high sensitivity troponin initially was 15, which then escalated to 16. Can Dr. Sraow, excuse me. Let me make sure I'm, Dr. Sraow, can you explain the use of the high sensitivity troponin?
So the high sensitivity troponin is essentially, it's going to peak higher, and we tend to use it more so for the delta trope. So if we see, in this case, the delta trope is quite low. It was from, I believe, 15 to 16. That makes the suspicion for acute MI lower. You could see here we have the implementation, and then the different thresholds that are shown on this graph.
Okay, and I just want to kind of explain this slide a little bit more in detail. If you can see here, sex-specific thresholds identified 5 times more additional women than men with myocardial injury. So type 1 and type 2 there versus non-ischemic myocardial injury. Then if you look to the other side there, despite this, women in general receive fewer treatments for coronary artery disease than men. So dual antiplatelet therapy, 54 versus 67%. And then really significant for coronary revascularization, 35 versus 57%. Oh, did we? Okay, there we go. So I'd like to open it up to the audience here. I believe you were told about our poll, so you can go ahead and text the code that is listed there with which decision you agree with regards to what the next steps for this case should be. All right, so I think we can tally that up. All right, got a smart audience. Okay, so the overwhelming response of 59% is to have this patient stay and of course order more non-invasive cardiovascular testing. So whether that's a stress test or a cardiac CTA. There are 35% of the audience that believes that we should go straight to urgent cardiovascular testing, so a coronary angio. And then we've got a small proportion there that wants to admit to the hospital for observation. And I'm glad that nobody wants to discharge this female home.
Can you remind us what the EKG showed?
Yes, let me jump ahead to that. Oh,
Was just
is
sinus?
it?
Yeah.
It was reported as no ischemic changes. I'm not sure if we have the EKG.
EKG was reported as normal, but
Yeah,
I think
okay.
the point was the paper that showed, so we'd have to do it with your lab because there's different high sensitivity cardiac troponin assays. But if it's the high sensitivity cardiac troponin I, if you use the sex specific thresholds above 16 nanograms per liter would be considered elevated for a woman. So in that paper that we just went over, it was 34 for a man and 16 for a woman. So she met the criteria for myocardial injury. Myocardial injury certainly can be a type 2 MI from our severely elevated blood pressure. But I think with ongoing chest pain that was responsive to sublingual nitroglycerin, you would have to also be thinking about type 1 MI and acute coronary syndrome because although the EKG wasn't specific, she had chest pain and positive biomarkers.
Yeah, I mean, I agree with, but one thing to keep in mind in terms of specific treatments that you're going to give this person, since the EKG is normal, and if you go in and cath, you're not expecting to find this because, as you know, troponins can come out of the myocardium, not because of infarction. The troponin was developed as a marker for ischemia versus MBCK being a marker of cell death. So just ischemia alone can release that troponin T or troponin I, more so with troponin T. And I think you have to keep in mind, if you're going into the cath lab, you're cathing this person, recognizing that you may or may not see anything. I mean, I probably would just do a CT angio.
Thank you, Dr. Roberts. So Alexis, after her blood pressure was stabilized with an antihypertensive, which was administered orally, she was sent home by the emergency department physician. He provided her with a new prescription for lisinopril and aspirin and suggested that she follow up with her primary care the following day. Upon going home, she called her sister, who happens to work in healthcare. By this time, the symptoms have recurred and now occurring at rest. it was suggested she present immediately to a different emergency department this time. So I want to highlight that women in cardiovascular disease accounts for about 1 in 4 deaths a year. I often talk to women and many think that breast cancer is the #1 killer, but it's actually heart disease. And it being the #1 cause of death in women, particularly in the United States, we certainly want to continue our diligent efforts in diagnosing and preventing this. Black women particularly, more than 1 in every 2 Black women have heart disease. And as Black women, there's even a higher chance of dying when they are afflicted with heart disease, especially if they are at a younger age. So young women, especially women of color, present with higher rates of an acute MI and comorbidity burden. So if you look at this line graph here, 1 in 3 patients with an acute MI were young. The atherosclerosis risk and community study, the ERIC trial from 1995 to 2014, huge number of patients, almost 30,000 patients between the age of 35 to 74 were evaluated. And of them, almost 9,000 were young. And they concluded that there's a significant increase in an acute myocardial infarction in those younger than 55 years of age. So age 35 to 54. And most pronounced in young women who had a higher comorbidity burden and were able to identify as Black females. So if you look at this, we were talking, Dr. Bond, many of the speakers have alluded earlier to how women receive different therapies compared to their male counterparts. And if you look here, the probability of actually receiving lipid lowering therapies and beta blockers and antiplatelet therapy, let alone coronary revascularization, is more likely in men than it is in women. So Alexis was discharged, and clearly her concerns were not really addressed, and she was not truly being listened to. And I'm sure everyone in this room knows that one of the worst complaints to hear from a patient is that they were not heard. Not feeling heard is not a nice feeling. With disparities in care that we see, ongoing studies have raised different practical, differential practice of medicine compared to the clinician's gender. So there was a JAMA internal medicine study back in 2016 that looked into the patterns of outcomes seen in those patients cared for by female physicians. And these studies really build on evidence that female physicians are more likely than their male colleagues to adhere to clinical practice guidelines, and that they're more apt to offer preventative care, patient-centered communication, and psychosocial counseling. And although getting to the bottom of these differences is tricky because there are several male cardiologists and other physicians who do listen to women, female patients, it is important to note that other studies have demonstrated that when male physicians practice with a diverse cohort of women, they tend to have better outcomes. So Dr. Sraow, do you believe Alexis's case would have a better outcome had her physician been female?
Well, I would say it's a confusing situation because there's great physicians from both genders. The data does unfortunately show, it suggests that that would be the case. Beyond the JAM article, I believe there's about 3 years ago, there's a similar article in New England Journal of Medicine that showed that outcomes were better from a female clinician, especially in this case with a female patient. So I would say that the data thus far is suggesting that perhaps a female clinician would have picked up on this a little bit quicker.
Thank you for that thoughtful response. So when in doubt, it's best to use a clinical decision pathway. There may be some limitations to this because they don't always address gender-specific risk factors. But as you can see here, you've got your EKG, you've got an assessment of risk factors in this female. You've got a female with chest pain or shortness of breath or a chest pain, i.e. an anginal equivalent. You've got your physical exam, and then you had a positive troponin. Your risk assessment here, that's what it should begin with, and then you can determine whether this patient would benefit from a stress CMR, a stress echo, a stress PET, a CCTA. And this really, you need to look at what is the pretest probability of obstructive CAD in a patient like Alexis. So if it's moderate risk, you really need to do further testing. If it's low risk, maybe you wouldn't order the test in patient. And there's lots of times that, maybe the cardiologist will say, well, we'll follow up outpatient and do the stress test or further testing. But I think the key here is to ensure follow-up as well. Now, even if we really followed the 2021 recently released chest pain guidelines from the ACC and the American Heart Association, we can see that the chest pain clinical decision pathway can differ based on each individual physician, but this is a good outline. If we were to calculate her heart score, which has its own limitations and does not include sex-specific risk factors, she would have still fallen into an intermediate risk. And in that study, these patients 17% risk of adverse cardiac events and were admitted to the hospital with plan for testing. And that just didn't happen with Alexis, perhaps due to implicit bias, age, gender, possibly race, we don't know. So let's continue on with Alexis's case, who's now presenting to a different emergency department, and see if we can get this right. Here's that EKG. So just to reiterate, normal sinus rhythm, no gross ischemia. Dr. Bellamkonda, do you believe that a CCTA is an appropriate test to proceed with at this time?
Yeah, right now the guidelines are shifting more towards anatomic testing, especially in low to intermediate risk patients. So I think the other thing we need to do is stop and recognize what she presented with. The chest pain, the troponins are rising. They're still within normal limits, but still if she continues to have symptoms, I think she needs anatomic assessment. So coronary CTA would be appropriate.
When would you, because it's sometimes hard to explain to patients as functional versus anatomical testing, what would make you prefer one or the other? How would you explain that to the patient?
Yeah. So for functional testing, you want, so anatomic, let's go with anatomic testing.
Yeah.
It's a bit easier. So that actually calculates percent stenosis. Say, for example, 10%, 20%, 30%, 60%, 80%. So for functional testing it's a type of test where you actually see, is it significant stenosis? So a patient can present with 60 to 70%, which is still technically, gray area, but it could be significant functionally, and it could be causing ischemia.
Right.
So that's the difference. So we choose patients based on their pre-test probability. Do we send them for anatomic versus functioning testing?
Right. Thank you. That's right. So I'm going to forward here to the actual Ccta images, which was done in this patient. And if Dr. Bellamkonda could review these with us, that would be great.
Yeah. So the coronary CTA, images, this is a non-invasive test. So it's an intravenous contrast. And we give patients beta blockers and nitro as well, so that we get really good imaging. On the left is left main and left anterior descending, as well as the circumflex artery. And the mid portion where the arrow is, that shows about 70% anatomic stenosis. And then the circumflex as well has significant disease.
Yeah, thank you. That's pretty evident there. All right. So here's the echocardiogram, which showed normal LV function, normal thickness. Ejection fraction was 60 to 65% normal, and normal diastolic function. Really, Alexis didn't have any hemodynamically significant valvular heart disease. She had some mild tricuspid regurgitation, and the pulmonary pressures were normal. Dr. Bellamkonda, do you want to quickly just address this right coronary?
Yeah,
image?
So the right coronary does show stenosis, especially the mid RCA has about 70% disease. Yeah.
Thank you. Okay, Dr. Sraow, if you could walk us through the Cath slides here.
Okay, so let's go forward. So I know we have people from multiple disciplinary, so I'm gonna just kind of go through the basics. This is the left coronary system, which is being injected by a catheter, which is putting contrast dye, which fills the lumen of the arteries. The arteries of the heart are like a tree. There's a branch, and then it goes into larger branches, and so on and so forth to smaller branches. We like to see when we inject the arteries for it to have a smooth surface. As you can see right at the beginning where the trunk is, where the catheter is injecting, there's some diffuse lumpy bumpiness that shows that there's diffuse disease at the trunk level. Then bifurcates into the large branches. We can go forward.
Mhm.
So the branch kind of coming down to the very tip of the heart is called left anterior descending, which feeds the front part of the heart and is the most important artery in the heart. You could see when we said that that trunk part was diffusely diseased, it should be larger than its branches, like any tree should. And you can see that even the branches have larger caliber than that left main. So there's certainly disease in that trunk area. And it should be smooth and thick throughout the vessel. And you see a couple spots. I guess I could point them out.
Yeah.
Let me just use this. So you can see it's kind of, here we go. You see a couple spots here. This is that same vessel that it tapers down quite significantly. And I'm going to continue. The circumflex artery, this is kind of light, but it's another main branch which has a very tight vessel on the top, which is called obtuse marginal 1. And you can see it nicely over here where this should be nice and thick throughout, but it kind of pinches down. This is not the traditional way to do a left ventriculography, but I presume this was done this way because an echocardiogram was already done. But this is to check the pressure and how the valve, how the heart muscle is pumping. And on the right side, this is what Dr. Bellamkonda was referring to, which is a very tight stenosis in the right artery. And then also you can see this tightening over here. So this is multi-vessel disease. We can move forward.
Thank you. Thank you, Dr. Sraow, for explaining that. Most of us general cardiologists, it's been a while. All right. So in light of this multi-vessel coronary artery disease, Dr. Mamas, would you ever consider multi-vessel PCI in this patient?
Yes, I would. I mean, what you've got to remember is that coronary artery disease is not something that's going to be cured by either a bypass operation or a PCI. She's still very young, and it's likely, even if she does have a bypass, that she will require PCI as the grafts go down. I mean, she is in her late 30s. She's probably got another 40 plus years ahead of her. So, you know, the data does show us that she will need further interventions down the line. These are focal lesions. I think they're eminently treatable with percutaneous coronary intervention. So I would certainly offer her that. And let's not forget that a lot of the discussion would be about patient preference. And certainly as a young, active person, if I had this coronary anatomy, I would not want to bypass. You know, I enjoy hiking, I enjoy running, I'm very active, I would want to get back to work quickly. I would not want a 3-month recovery from surgery. I think to formalize this, we would need to calculate a syntax score. If the syntax score was intermediate or high, that would probably push me more towards surgery. If it was low, and these are focal lesions, then I would, you know, certainly offer the patient PCI, but with intravascular imaging, because we know that intravascular imaging reduces target lesion failure by 50%.
Yeah, thank you, Dr. Mamas. That lifestyle is certainly important to consider as well, especially in young patients. I think you've also answered the second question that I had, which was, would IVUS make a difference here? Would it have played a different role?
Yes, I think IVUS is critical. Number one, to assess the left main. I think if the left main was found to be significant on IVUS, that would push me towards surgery. Secondly, I personally don't think that operators should be doing PCI unless they do IVUS or OCT, which is what I use pre and post. There's 10 randomized controlled trials showing improved outcomes associated with IVUS use in PCI, both for simple and complex lesions. So operators should not be doing PCI without routine use of IVUS.
Yep. Thank you. Dr. Brady, our surgeon, why may bypass be preferred in off pump versus on pump?
Well, I think maybe going back to the strategy of PCI versus CABG, who wouldn't want a CABG? Apparently nobody wants a CABG. It's an invasive operation. And I do take a little offense to the fact you can't hike again. So, people do regain a good functional status. It is a 2 to 3 month recovery. But we're looking over the lifetime of a person. I say this to patients, what is that 2 to 3 months over a 10-year period? And we'll soon forget about COVID. You'll forget about that. It'll be a memory, but you will regain your functional status. And we've done this operation on people who've gone back to be athletic, run marathons like one of my patients doing. I mean, you can go back to functionally. So, but I think the good point here is something that I say to my younger patients. I change the pipes, but I don't change the water. And whatever we do here, it's palliation. There's no cure if it's PCI or surgery. So I think the first question is surgery versus PCI. And I understand that point because we're going through a lot with tissue valves and aortic valve replacements. What's the best thing for the long-term 40-year strategy? I would beg to differ. I would say in a young person, triple vessel disease with or without left main component, especially in a diabetic or somebody's got some LV dysfunction, but in this patient with a significant burden of triple vessel disease, studies show consistently over and over again, there are better rates of durability and therefore less revascularization and myocardial infarction and MACE events over the 10 to 12 year period with surgery versus PCI. So if you look at this person over 12 years, there'll be a 40% revascularization with PCI and 20% with surgery. And after that, it sort of goes to become a little bit more difficult. And as a surgeon, I'm not saying right or wrong here, but evidence-based medicine would suggest there's a benefit for people with triple vessel disease who are under 50 with surgical revascularization. My concern sometimes with PCI is if you go down that road, you're going to go down it again and again and again. You're going to lose these vessels, or you're going to be in a situation where it makes it more difficult for surgical revascularization because of landing territory for the grafts. So I would say off the bat, I would offer surgery based on the facts that we know. Even that journal article came out in 2020 showing those kind of results of a benefit for surgery. So off pump, on pump, we could have an entire day's discussion. I think I did last year on the Ruby trial, comparing on pump and off pump. And a lot of those centers like ours who do 99% plus off pump surgery, we know in women and we know in younger patients that we can have better results. Now, the Ruby trial didn't show that. That was a study done in the VA medical system that showed less grafts were done off pump and less patency rates. And that's a big deal. And if you get experienced centers for the people who do a lot of it, I think, and those smaller studies show a benefit off pump in women. So that, I think last year we presented that paper with a 23% reduction in complications with off pump surgery. So I would choose the off pump route. And again, I'm not here to arm wrestle anybody over PCI versus surgery, but I think we need to kind of really be focused on the long-term game plan with this person, because I also wear the hat of the mechanical circuit surgery port and transplant, because you got to be thinking about that down the road. I mean, this is not a game that's going to end. This is a 40-year battle. And so we got to pick our starting point pretty correctly.
Yeah, it is certainly important given her age.
Am I talking too much?
So I just had a quick question for Dr. Brady. So Dr. Michos suggested that preference would be a major factor in this in terms of patient preference. And of course, you said that no one would really prefer bypass if there was an alternative. So how do you present this to the patient? Because I do agree that PCI would be difficult here. It would take a number of stents and probably different stages.
So it's interesting about that. Honestly, that's you. I mean, how many times am I invited to that discussion? And how easy is it to make that sale? Do you want some guy to come in and rip your chest open, or we can put in some stents? I mean, I would choose the stents. I mean, that's a difficult situation. And I think the greatest programs we have are multidisciplinary and where we have conferences where we can really discuss and be truthful to each other about discussing that, because the patients aren't always given a choice, and it's a hard sell. And don't get me wrong, I mean, people refuse me all the time. I don't take it personally, but I think explaining the facts is very, very important. I'm going through this with tissue and mechanical valves right now. Nobody wants a mechanical valve, and yet the data shows higher survivability under a certain age group if they get a mechanical valve. And once you know that, once you let people start making these decisions based on what they see on the internet or their friends tell them, you're not using that evidence-based practice. So if I'm invited to the discussion, that's wonderful, and then we can present the rest. And I'm more than happy to sign off if we're not invited to the party. But I think really kind of going through that with them is a pretty good discussion. And luckily we had this opportunity with this lady to really have that, and she chose obviously to have surgery. So, but I would say, and I don't know, you can tell me because I'm not there, but how many cases is that discussion not made? I mean, how many times is that discussion made at the moment at the diagnostic heart catheterization to proceed with one therapy over the other?
I mean, the one point I would make, though, is that this lady received saphenous vein grafts, and we know that the 10-year occlusion rate of saphenous vein grafts from CTs is over 50%. And so really, in such a young patient, I would certainly be pushing the surgeons to be doing full arterial revascularization, which we know has much better outcomes. And we also know that there are major sex disparities. Women are much less likely to receive full arterial revascularization despite better outcomes.
And we're going to touch on the arterial grafting here shortly.
Yeah, thank you for those important points, Dr. Mabus, and thank you, Dr. Brady. Hopefully there's no fights between IC and CT surgery. And yes, so Alexis, our patient, has chosen off-pump four vessel bypass, and so we'll move right along here. So where does Alexis go from here? We really need to be cognizant, I feel, of these 5 important points from this case. Sex-specific conditions should be considered a major risk factor. We need to be thinking about how they present to us. If you have a history of hypertension, gestational diabetes, gestational hypertension, you should undergo further cardiac risk stratification. And to Dr. Rubenstein's point, I think it's really nice to have a relationship with some of the OBGYNs who after delivery are very cognizant of this and are making those referrals and ensuring their patients follow up with cardiology, if at least not us, at least their primary care. Symptoms among women, I feel like I say this every year for the last so many years, but need to be taken seriously. I can't tell you how many times, sometimes in the hospital you hear, well, she's just anxious or she's crazy or, she's been here so many times. We get into this mindset or judgment, and we really need to stop that. We should take patients seriously no matter what their age, particularly. And negative cardiac biomarkers don't necessarily imply that there's no evidence of acute coronary syndrome. We know particularly in women, there's microvascular ischemia. How many times have I, maybe Dr. Naik knows, I've asked him to plump up the arteries with some nitro. There's no obstructive CAD, but sometimes there's other things going on, particularly in women, that need to be identified. The minority women, particularly African-American and South Asian women, have an increased risk for cardiovascular disease. And these discussions on long-term outcomes of reproductive health, menstruation, again, the history of gestational issues really need to be taken into account, because many of these women are young. They're in their 20s, they're in their 30s. And if we don't impact this early on, it's really a tragedy when they show up to me in their 50s or 60s. And, nobody ever talked to me about my risk factors, or I didn't know that having that hypertensive crisis was going to lead me to be on antihypertensive therapy later on. So I think more and more, if we keep these little thoughts in our minds, we'll become better clinicians than we already are. So thank you for your time. And I'm going to hand it over to Dr. Bond right now.